Thank you, Madhya, and thank you, PSIM, for giving me this opportunity to talk about a topic, and thank you, Professor Aftab Mohsin, for choosing the right time. After achieving the physical health, we're now talking about very important male sexual health and male hypogonadism. So the topic actually is one of the most commonly talked topic, but unfortunately underrepresented topic because of cultural barriers, because of personal barrier and shyness. A lot of male patients, they don't come or seek help for this particular problem. And in most of the cases, it's either overdiagnosed, but even more commonly, it's underdiagnosed. So today, I would try and demystify that what actually is male hypogonadism. Now, we talk about thyroid function, we talk about liver function. We need to start talking about testicular function, because testes are hormones, and hormones as such have to have a function. And the two most important, or the two main function of testes are production of testosterone and production of sperms. So if someone has got genuine hypogonadism, they won't be able to produce the testosterone in the right amount, and they will be isospermic or oligospermic. So this is very important that we take both into account. And that leads us to the next part of the presentation, which is, first I'll talk about the hormonal aspect, and then I will touch base just briefly on the infertility aspect, because unfortunately there are not very many specialists who can deal with male infertility. Now, the major problem we have been having is a lot of societies and a lot of specialities have been dealing with hypogonadism. And I just tried to summarize different societies of the word defining hypogonadism in a different way. It is very important that when endocrinologists talk about hypogonadism, we talk about both function, which is which is the testosterone production and the sperm production. While when we talk about usually our andrologist or urologist colleagues, they usually talk about erectile dysfunction and production of testosterone. Briefly about the symptom which we come across. Now, unfortunately, these are very common non-specific symptoms. The most important specific symptom is infertility and azoospermia. Rest of majority of the symptom, for example, gynecomastia can be because of various drugs, and it can be because of obesity. Similarly, fatigue is one of the most common presentation with testosterone deficiency. Again, fatigue is common in so many other conditions. Reduced libido can be because of stress. So these are not telltale sign of hypogonadism. We have to take the whole clinical context into account when we make a diagnosis of hypogonadism. However, in an otherwise young male, if someone is coming with osteoporosis and osteoporotic fractures, you have to first think about hypogonadism, because structural and bony health is one of the major important contributor of the testosterone deficiency. So basically you can divide the symptoms into 5. Sexual, which includes reduced libido and erectile dysfunction. Metabolic, it will lead to obesity, sarcopenia, as well as increased fat formation and metabolic syndrome-like picture. Physical, like gynecomastia or testicular atrophy. Vasomotor, like flushing, like women get in menopausal, so main menopause as formerly known as. And reproductive, which is infertility. Now, erectile dysfunction, I just wanted to clarify that a lot of people think erectile dysfunction is because of hypogonadism. About 40% of erectile dysfunction is because of hypertension and hypertensive drugs, or the polypharmacy, about a third of the cases. So not all ED, erectile dysfunction, are because of hypogonadism and vice versa. So when we talk about it, it is very important for us to differentiate the cause, what's causing hypogonadism. Primary, which is very easy to diagnose, and that is when testosterone is low, but LH and FSH level are too high. Testicular Klinefelter syndrome or orchitis, mumps, previous mumps, is very common, and usually it's diagnosed very early on. Then the most common cause actually is the secondary, and the secondary is central. I usually call it central hypogonadism because it's hypothalamic, which is even more common than the pituitary causes. So it's central versus primary. Now the approach. The approach is very simple. First of all, if you're testing testosterone, please make sure you get a fasting 9 o'clock blood sample. Because the testosterone level is 15% higher when it is tested in a fasting at between 8:30 and 9:30 a.m. If this is checked after midday, the level dropped by more than 50%. And we will be erroneously diagnosing someone with hypogonadism and subjecting them to a treatment which can be potentially leading to serious health consequences. So it has to be fasting and it has to be early morning. Then if the testosterone is low, then low or borderline, you have to repeat second time. This is very important because if someone is a shift worker, or someone could not sleep well that night, their testosterone can be low in the morning. You need a proper night's sleep to kick in your circadian rhythm to produce testosterone. So you have to repeat it second time to make sure. Then there are two categories, LH and FSH. They can be low or they can be high. If the FSH is elevated, primary hypogonadism, go for the karyotyping, Klinefelter. If LH and FSH are normal, which is inappropriately normal, so we don't call them normal, we call them in reference range. If they are in reference range and testosterone is low, then they are inappropriately in the reference range. They need to be higher. So if they are low or even normal or reference range, then this is secondary hypogonadism. Then we proceed to the proper workup of secondary hypogonadism, which is prolactin. If you have to do one test, just do prolactin, because that's the most important one to cause secondary hypogonadism. Now, a lot of the time you will see that there is no obvious pathology, there is no obvious reason for secondary hypogonadism. And it's a gray area. And that's where majority of the chronic illnesses and lots of other drugs, they are playing their part to cause hypogonadism. So, again, the same diagram. Now the cause is hypothalamic. Now, hypothalamic causes are more common in female. Female who do a lot of exercise or have anorexia nervosa, they have period problems. While in male it's less common, but still it is a well-recognized factor. Hypophyseal, which is pituitary, I talked about the prolactinoma. Then systemic and the drugs, a lot of drugs can cause hypogonadism. Target organ-related, 5-alpha reductase inhibitor we use quite commonly, and testicular, which is primary testicular failure. Now, this is very important slide again. Testosterone, historically and especially in non-endocrinologist category, is total testosterone is taken as diagnostic. It is not always the case. Testosterone is found in 3 different forms: free form, loosely bound, and completely bound. The total testosterone is basically a combination of free testosterone. So let's talk from the free testosterone maybe. So free testosterone, which is not bound to protein, and it's only 2%. That's the most important and active testosterone in the body. Bioavailable is free testosterone plus the albumin bound. Testosterone binds very loosely to the albumin, and it can be available on demand in most of the cases. That's why it's called bioavailable testosterone. And then the total testosterone is a combination of free, sex hormone binding globulin, and albumin. So it's basically a combination which is 98% bound and only 2% free. So total testosterone can be normal, but free testosterone level can be quite low and patient will be hypogonadal. So we need to somehow establish what the free testosterone is to actually say whether this patient has hypogonadism biochemically or not. Now, SHBG, it's very important to understand what factors affect the SHBG. And the most common factor is estrogen. Now, male don't take estrogen, but you know where estrogen comes from in a male person? The testosterone goes in the fat tissue, and through aromatase enzymes, it is converted into estrogen. Chronic liver disease. So the high estrogen level will cause the high SHBG, and SHBG basically mop up the testosterone. Then decrease SHBG, androgen, if someone is taking or abusing androgens, hypothyroidism, glucocorticoids, or even obesity. So obesity is a little bit of a difficult one because the total testosterone is reduced. But because of low SHBG, bioavailable testosterone increases. So it evens out in most of the cases. But if obesity is quite severe and associated with obstructive sleep apnea, then the total testosterone goes significantly down because body can't produce testosterone as circadian rhythm is disturbed due to obstructive sleep apnea. So to make a diagnosis, you need to have a clinical evidence, gynecomastia, testicle atrophy, reduced shaving frequency, metabolic effect like metabolic syndrome or osteoporosis, and biochemistry, which is low total and bioavailable testosterone. Now, I know it's a resource-limited country, and having too many frequent investigation may not be possible all the time. So simple, if you have to rely on just total testosterone, and the level is about 12, forget about hypogonadism. Because even if there is small degree of hypogonadism, I'm not going to treat it. It's usually transient, and the benefit of testosterone are not well established if the total testosterone is over 12. Less than 8, you can start testosterone treatment because this is a group where the benefit of testosterone levels are well established. Between 8 and 12, now this is a difficult one because this is a gray area. So what I do, I check or calculate. Never request a free testosterone from the lab. It's not very accurate, and especially if the mass spectrometry analysis is not available, it is not very authentic. So always calculate the free testosterone. And free testosterone is calculated, just go to nibido.com and there are calculators available online. You just put the SHBG, albumin, and testosterone level, and it gives you the free testosterone, free of cost. So rather than getting it tested, it's very expensive and unreliable. Just use this equation. This equation actually correlates much better compared to the actually measured free testosterone. If you're not sure about symptoms, you can use the questionnaires. Now, just a quick scenario. 79-year-old male. History of fractured neck of femur. Low impact fracture. Mildly anemic with normal MCV. Reduced shaving frequency, sarcopenia, fatigue, and reduced exercise tolerance. He has hyperhidrosis. The diagnosis? Hypogonadism. Now, a lot is talked about that at this age, testosterone shouldn't be given, while this makes the case, especially if there are objective findings like osteoporosis, anemia, and fractures. Aging men, Professor Aziz was talking about his topic of interest, and there are lots of studies which confirm that osteoporosis is in fact associated, and hypogonadism is associated with increasing age. Now, this is the reason the total testosterone production is dropping. Free testosterone is dropping. But the sex hormone binding globulin, the globulin which mops up the testosterone from the body, is increasing. So unfortunately, it's a dual-edged sword. So A, the production is reduced, and then it is cleared by SHBG or bound and made inactive by SHBG quite readily. And these are the male hypogonadism metabolic effect leading to metabolic syndrome and chronic inflammation and increased mortality. This is an independent marker of cardiovascular disease, whether the vasculopathy is associated or whether through metabolic syndrome is an area of debate, but I think it's a bit of both. South Yorkshire studies. Now, South Yorkshire, lovely part of the world, very nice people, but unfortunately, as it looks like, half of the male are hypogonadal. And about 50% of the ischemic heart disease patients, they had hypogonadism. Now, men with coronary artery disease have lower bioavailable testosterone, lower free testosterone, and lower total testosterone. It's very interesting. Lipid profile. Now, this is a difficult one because if there is testosterone deficiency, triglyceride and LDL cholesterol increase. And if we give testosterone, HDL level drop. So it's a little bit of equivocal. Now, this is what I was talking about. Increased fat tissue, and increased fat tissue would lead to conversion of testosterone to estrogen. And estrogen will lead to hypogonadal feature. We talk about osteoporosis. Now the death. This is a very alarming article published in Archive of Internal Medicine that all-cause mortality is increased in hypogonadism. So, treatment. How to physically improve testosterone. A good night's sleep is very important because you make your circadian rhythm kick the production of testosterone. Lose weight because fat is a factory of estrogen formation in the male body. So we need to keep the testosterone in the form of testosterone. Low carb diet, maintain a healthful diet and regular exercise. Smoking and alcohol is a well-established fact are causing hypogonadism. Testosterone preparation, the ones I use, there are numerous preparations. But the ones I use, I always start with the gel application. And that is because of two reasons. Easy and convenient, short half-life. If they have any problem or reaction to testosterone, you stop it and the next day they will be fine. The most important thing to understand and tell your patient when they're on topical testosterone is in the morning you have to have a shower, towel dry skin, you apply the gel on a non-hairy part of the skin, and then wash your hands properly with a soap and let it dry before you put the shirt on. Because if they touch their partner with those hands, they can give testosterone to female and they become hairy and they won't like them. And if they're pregnant, that can be quite dangerous. I had a patient who was actually having and applying testosterone before the sexual intercourse, and that actually is directly giving testosterone to the partner. That's not safe. Once they are established on the gel, I give them the injection. And my usually first line is Nebido. Nebido is 1 gram. It goes in the bum, intramuscular injection, and once every 3 months. Usual frequency is 10 to 14 weeks. So we check testosterone level before the next dose, and if the levels are below the treatment threshold, we can reduce the frequency from 12 to 10 weeks. There is also an oral form which I have never used because I think it's a little bit gross. Diagnostic evaluation. So presence of at least one symptom and sign, erectile dysfunction, assess testosterone, less than 8, treat. 8 to 12, evaluate. More than 12, do not treat. So summary, prevalence is very high, and male hypogonadism is associated with severe sign and symptom and affects quality of life. And a diagnosis of male hypogonadism comprises clinical, biochemical, and monitoring of the same. Now, erectile dysfunction, I will just briefly touch base. It's one of the most common presentation in a general medical practice, especially if you're dealing with chronic diseases. And there is a lot of anxiety about reduction in dimension, like reduction in the size and girth. And there is a paper that this is true, especially in people with diabetes. As I mentioned, only 40% of hypogonadism cases, only 40% of erectile dysfunction patients have hypogonadism. There are so many other factors, which are arterial factors, neurological factors, endocrine or hypogonadal features, and psychological factors. First line treatment for erectile dysfunction: weight loss, increase exercise, stop smoking. PDE5 inhibitor, usually sildenafil or tadalafil are the ones we commonly use. These therapies, they have been used, and I think usually the go-to is either Cavaject or the pump. Pump is quite easy, and especially if someone has prostatic surgery, this is the treatment of choice, because during surgery, there is damage to the nerves, and if someone wants to understand the use of the pump, I'm more than happy to have a separate conversation that how it is actually used, because there is a very delicate trick about it, but this is quite effective in these patients. So, erectile dysfunction, it's endothelial dysfunction, educate, get a disciplined lifestyle, early detection, and it can cause early death. My last part, 35-year-old male, he is athlete, he's married for 3 years, has been unable to father a child for the last 3 years despite having regular intercourse. No history of any chronic illness, reports reduced libido, and has professional body build. He's azoospermic. So what I do is first I send them to urologist and they check the plumbing issues. If there is any blockage of release of the sperms, that need to be addressed. But if the volume is normal, Then I check the testicular volume. If the testicular volume is low, then I look at the FSH. If FSH is high, you have to go with the testicular microdissection and retrieve the sperm. And my andrologist colleague who I work with, he is very expert in it. But if there is secondary or central hypogonadism, I use HCG. So I use HCG, usually 1,500 to 2,500 units, 3 times a week. And in about 60% of the cases, at 6 months, their sperm count increases up to 4 million. Then you measure testosterone and sperm count. If the fertility and concentration has improved, that's fine. Otherwise, I add FSH. It's recombinant FSH, which basically kicks in the sperm production. And this can continue up to 2 years, and the success rate in central hypogonadism is about 85 to 90%. My last slide, clinical suspicion of hypogonadism. First, history taking, then biochemical evaluation. Look if anything is reversible. Obesity nowadays with new medication is reversible. Is it central? Is it medication related? Opioids are the most common cause. Aging are unlikely to reverse. So if there is reversible, go for the kill, go for the reversal. If it's aging, then you need to have a conversation with the patient and have your own clinical judgment. And if it is unlikely to reverse, please go for the testosterone treatment. Thank you.